Hi, and welcome to the show. Rate and review at kevinmd.com/rate. Subscribe at kevinmd.com/podcast. Today in the show, we have Sue MacLellan. She's a pediatric cardiologist, and her Kevin MD article is titled Institutional Betrayal versus Courage. Sue, welcome to the show.
Thank you, Kevin. It's great to be here. Nice to meet you.
So we'll get into your article in a little bit, but first off, briefly share your story and journey to where you are today.
Sure. So I am a pediatric cardiologist by trade, and I've been in practice for 25 years in the Midwest, originally from Alberta, and so the Great White North. And I play a lot of roles. So I'm a mom, I'm a spouse, but one of my other kind of side gigs that I've been doing the past 4 years internally at our institution is I also practice as a physician coach. And so we offer those services to our clinicians, and we've actually grown a wonderful little support team at our institution. That's my
Typically,
story.
typically when I hear about physician coaches, they're outside an institution or hospital. So it sounds like this one was kind of formalized within your institution. So tell me how that program works.
Sure. So I stumbled across physician coaching about 5 years ago as we were developing a wellness committee, looking at, hey, how is our resilience and our well-being amongst our clinicians? We'd gathered some internal burnout data. And I did a little retreat at one of coach offerings that's out there and came back and said, you know what, this would be a super thing to offer our clinicians. And so we developed a program. 5 of us have trained. We took a 6-month training program, and we offer free coaching to any one of our almost 1,000 clinicians, including physicians and associate staff. And we fit it into their schedule. We have FTE set aside for it. We do department coaching and individual coaching. We work with our trainees, and it's really actually become a very robust program. Um, Now we have previous clients, previous coachees referring others for coaching. The marketing piece of it, we wondered how that was going to go, and it's just expanded exponentially.
Yeah, tell me about that initial reaction when your institution introduced that, hey, now we have clinician coaching services. In general, at first, what was the initial reaction?
So when we developed the program, we wanted to make certain that people knew it was not penial, it was not remedial. We work with our EAP, but we're about physician development. So where do you want to go with your career? How do you want to improve communication? How's your conflict resolution going? And, there was some resistance. I think we sometimes, as physicians, come with the mindset that, well, now they must think I'm broken and they want to fix me. And in fact, coaching is just the opposite of that. And you're probably well aware of this. We view the individual as whole and they can figure out their own life. They're creative in their own way. So once I think people began to understand that coaches are coming alongside you like a thought partner, like an expert companion, like an advocate for you. It's not our agenda, it's not administration's agenda, it's your agenda. Then I think it just really caught on after that.
Now, are all the coaches within your organization, are they also physicians?
3 of us are physicians and 2 are associate staff, so a nurse practitioner and a physician assistant. And that's kind of the latest branch of our service is adding those 2 coaches in. There's just as much challenge, stress, burnout, desire to move forward in careers amongst the APCs as well. So it's been a really good addition.
Now, when coaching physicians, how important is it that you're a physician yourself?
I think that's a preference, but what's interesting too is I think once physicians experience coaching, they realize that, it doesn't necessarily have to be a physician, but someone who understands healthcare because it's such a strange world we live in. And so that piece of it, I think, is the biggest component.
And before we get into your article, just let me ask, what are some of your most common issues that you have to coach physicians about?
Yeah, career decisions. We went into some of the development thinking, well, maybe this is a way to retain physicians, right? We don't want them all heading out the door and changing careers and leaving the institution. But in fact, sometimes as people find themselves, they find their stride, they become more self aware. How can I actually honor my values and what I want to do in life? Um, People move on. And so I think it's been interesting seeing how those career decisions evolve. Certainly, when we work with departments, a lot of it is how can we better communicate? There's misunderstanding here, conflict, and so that's a big part of it. And then one of the other areas is about finding your purpose. Why are you doing what you're doing? Why does your team do what they do? What are your team values, your individual values? So that's kind of the top ones we touch on.
All right, let's talk about your Kevin MD article titled Institutional Betrayal versus Courage. Now,
Yeah.
how did this article come together?
So there's been a little theme, Kevin, that's come up for us as a coaching group about trust within institutions. And I do some outside coaching as well. So this isn't unique just to our institution, it's a theme. We've come out of 2.5 years of chaos. Now we're exhausted. We're kind of in this sympathetic overdrive, and changes are still occurring. And so, as organizations begin to say, yep, we got to do something with our short staffing, you need to improve efficiency, you need to see more patients, you need to step up your game, more rules, regulations coming down from above. I think it's only creating this hypervigilance, clinicians. And so, there's pushback, there's anger, there's frustration, there's feelings of betrayal. And so, how can an institution look at this differently? I think was really the purpose behind my commentary. How can we be kinder to one another? How can we preserve each other's dignity, make us worthy of respect? How do we clearly communicate so the message is not misconstrued? What are our expectations? That's a big one. How do we manage our expectations? How do we communicate them clearly? And so some of the work we do actually is between managers and clinicians or administration and clinicians, that advocacy piece that the clinician is not alone as a tiny little voice in the wilderness. There is a way to really come to agreement in how to move forward for the betterment of everyone, not just the institution.
Now, tell us an example, case study, or story of how you bridge that gap between administration and physicians, because that scenario that you initially talked about it rings true. If an organization tells a clinician that they have to increase their RVUs, if they have to see more patients, there is that sense of betrayal that you exactly described. So, tell me how you move the needle when it comes to bridging that gap and having someone come to an understanding.
Sure. I'm going to give you an example from yesterday, a conversation with a manager who had to deliver some hard messages earlier in the week to the clinicians. And the message was you're going to see more patients, you're going to have these contact hours. There was some changes in vacation
Hmm.
allotment. So just a lot of disturbing news for the clinicians when they're already feeling strapped. And I was witness to that conversation and went back to the manager afterward. And I said, I just want to share a little bit about kind of the personality and style of clinicians, how they like to receive new information that may affect them personally. We had a really good dialogue. So, just in a nutshell, the persona of a physician, we begin to shift when we begin to get indoctrinated in medical school, right? Highly competitive environment. We're kind of special. We made it through a lot of tough assessments to get to where we are. Our egos can be kind of big in the moment. We like our autonomy. We get out into practice, and what we've now seen as the autonomy becomes more restrictive, more rules and regulations to abide by just to simply play in the sandbox. And so, how a message can be delivered from a manager actually ties into something that I love to read about, adult development theory. If you're a fairly high functioning adult, we don't like to be told what to do. We want to be engaged in the conversation. We want to join in, maybe bargain a little bit back and forth, sort of work on the outcome together. So if a manager comes and says, this is how it's going to be, there's no choice in the matter, you will do this, clinicians will immediately flare and you'll see the anger, frustration, this sense of betrayal. If a manager was to come and say, hey, this is hard news, your physician leader, invite them into the conversation. You might not like what I'm about to hear. How can we work on this together? I want to be clear that, these are kind of mandates that are coming down, but we want you to have a voice. We want you to share. We want you to share politely and to really kind of work on that communication piece. Then sometimes the manager is able to diffuse a situation before hackles get raised. Just a small example.
Now, do you feel that most administrators do they have to be told, like from yourself, in terms of how physicians may take that news, or would their default be some type of top-down style?
Interesting question. So, top down is our default style. And I think that's where we go, even as clinicians, how we want to manage the situation when we're feeling threatened. And administrators have a sense of duty very often, very strong to the organization. So, something that can happen even in physician led organizations is objectification. So, I think this actually is in one of my other blogs that I've shared, where instead of me being a human being in the trenches working to serve my patients and having this huge commitment to both the institution and patient care, I begin to be viewed as a widget. And so I'm just told what to do and I should get that job done, and then they're going to go and tell me something else to do. Maybe no human aspect to it anymore, just another cog in the wheel to move that healthcare process forward. And so I think all of us have to be very mindful about objectifying one another. I can do it to my nurses when I'm working with them. Just hand me that, get it to me, let's get the job done, and forget that there's a human being attached to the other end. When our bandwidth is short, we don't have a lot of time, it's easy to do that. So I think being careful about objectifying one another, making that human connection is really important.
And you mentioned when you gave that feedback to that manager, it was constructively received. So go into more detail. Like, what exactly did he or she say or do?
Yeah. So, I think I want to be gentle when I'm providing feedback. I just want to share my perspective. I'm not telling you how it is. So, sharing perspective is really important, setting the stage for an open conversation without defensiveness coming into the situation. And so, sharing perspective, I think that she was very open to it. She's been around the block a few times herself. She's like, I know that. They don't like being told what to do. Gosh, we actually could have used more physician leader support in this. Hey, how do you want to do that in the future? Let's empower our physician leaders to support our managers too, so that we can have these conversations that are going to go in a more positive way. So, actually, she was very receptive to it.
We're talking to Sue MacLellan. She's a pediatric cardiologist. Her Kevin MD article is titled Institutional Betrayal versus Courage. So, Sue, going forward from a clinician standpoint, I'm sure that a lot of these conversations that you described, these difficult conversations from administration is going to be more and more frequent. So, as clinicians, what can we do to be more involved with that conversation and be involved with that decision making process? Any advice that we can give to clinicians, or else we risk just being, like you said, told what to do and we won't like it? How do we just prevent ourselves from being in that position in the first place?
Right. So, just as a little set point, being a coach is not about being an advisor. So that's one of the points that we really make is I'm not a big advice giver. However, you're inviting me into this. So I think it's about being aware that other perspectives exist,
Hmm.
being aware that I have my own expectations, as does the person in conversation with me. We
Hmm.
have our own goals that we want to achieve in that conversation, and then being intentional that we're going to move forward in a positive way, in a kind way, in a way that preserves the dignity of the other person, that preserves the safety of the situation. And when I say safety, I'm kind of talking about these little micro betrayals that, gosh, you kind of talk to me in a sharp tone or an offensive way. Let's even it out and become the observer of the situation rather than invested in the weeds where we're judging and blaming.
So, at the moment, sometimes that can be very difficult. So, at the moment, let's
Very
say if you're
difficult.
coaching a clinician and, like you said, a manager just comes in abruptly says, "This is what you have to do. You have to see more patients. PTO is going to be decreased." What are some things clinicians can do at the moment to perhaps appreciate some of those other perspectives?
Right.
Because it's very emotional. It can be very
Right.
difficult.
Right. So you being caught off guard, right? I love it that you bring this up. So this takes practice. It's a mindset shift. You have to find your little cue when some painful arrow is thrown at you that's going to allow you to pause and think before you just simply react, before you flare up or you spout off. And so it's not perfect, right? By no means am I perfect, but practice helps. And this is like 8 years into it. And I would say that when somebody slings something offensive at me in the moment, I have a little technique, which is to pinch my fingers together because I'm feeling a little aggressive and I'm going to take a deep breath, pause, and I'm going to harness that moment of time. I don't have to immediately spout off. That might be what my amygdala wants to do,
Mhm.
but I don't have to. I have a choice. And so finding a little way to practice, and maybe if it's only successful one time in a week, you've done it. You've held your tongue, you've paused, you've thought it through, and you've chosen to respond rather than just simply react.
And my final question: what are some of your take-home messages that you want to leave with the Kevin MD audience?
I think we're on a new horizon. Trust is breaking down. We're exhausted still. We're all on this hyper alert type journey. And so take time for yourself. I know that might sound like kind of that canned resilience comment, but it's vital. Medicine does not have to be our be all and end all. There's so many amazing other wonderful things and people that we can connect with in our lives. And I just encourage people to do that. Like just look for that breath of fresh air in the moment.
Sue, thank you so much for sharing your time and insight. And thanks again for being on the show.
Thanks. Thanks, Kevin.